My name is David Josephson. I'm a board-certified urologist, urological oncologist, and robotic surgeon. My training is fairly unique in that there are very few urological oncologists or surgeons out there that have had extensive background in cancer surgery and are then able to safely apply those same techniques to minimally invasive surgeries such as robotics or laparoscopy. I first did a urological oncology fellowship at Norris Comprehensive Cancer Center under the tutelage of Dr. Donald Skinner, who's considered the so-called father of urologic oncology, and then had some extensive training in both laparoscopy, advanced laparoscopy, and robotic surgery, and then was recruited to City of Hope to lead the robotic surgery fellowship program and also become the surgical director of the kidney cancer program. I was able to apply that background to help establish new innovative techniques for doing partial nephrectomy with minimal or no ischemia, and also came up with new techniques to preserve the neurovascular bundles and continence mechanisms for getting patients after a prostatectomy to achieve their urine control and potency in a much faster time period. I currently practice at Cedars-Sinai Medical Center, and I'm also part of the Tower Urology Institute for minimally invasive surgery and robotic surgery. So for the past century, majority of surgical procedures, whether it's urologic or general surgery procedures, and in terms of urology procedures, any of the cancers of the urinary tract, whether it's bladder, or kidney, or prostate cancer, usually required big incisions to get access to somewhat difficult to achieve locations. So there are difficult spots, and these bigger incisions were usually associated with more blood loss and more complications. Now, we've certainly had advancements with general laparoscopy by making smaller incisions to get access to these difficult spots. But some of the limitations with pure laparoscopy is that it's two-dimensional visualization. The instruments are non-wristed, so you can't achieve the same degrees of movement that you can with your normal wrist. And this is where robotic interface came in to overcome some of the main limitations of pure laparoscopic surgery. So robotic surgery was developed as a way to maintain the advantages of pure laparoscopy, smaller incisions, and maintain the advantages of less blood loss and postoperative blood transfusion. And robotic surgery really embodies a master-slave type of configuration where I, as the operating surgeon, sit at a console, not physically connected to the patient, and I manipulate these instruments that can move in 7 degrees of motion within the patient through these surgical joysticks within the console. It lacks any tremor, so there's no shaking. I have 10 to 12 times the magnification that I can achieve with my normal eye. It's three-dimensional, so it gives me depth perception that you cannot achieve with standard laparoscopic instruments. And these miniature robotic instruments move in real time exactly the way that I would move my hand. So if I want to scale my movements to make a big movement on the outside translate to a very small movement on the inside, I can scale those instruments. So some of the advantages of robotic surgery include a more precise way of doing the same operation because there's less trauma to the tissue. It may lead to better recovery as it relates to potentially urinary control and potency after operations, for example, for the prostate. Because there's smaller incisions and less blood loss, there's less transfusions, a shorter hospitalization stay. We use less narcotics to control the pain because there's smaller incisions, and potentially less complications overall and faster recovery for the patient. So in a very short time period, maybe in a matter of 5 years, robotic-assisted surgery has become the surgical treatment of choice for patients with clinically localized prostate cancer. So robotic prostatectomy is the #1 chosen operation when it relates to robotic surgery. And I think other fields are going to see the same adoption in non-urologic procedures such as gynecology or minimally invasive operations for the heart. And robotic surgery is really a platform or a foundation where other things can be advanced on. So new techniques or new modalities, whether it be new instrumentation or electrocautery methods that are applied to the robotic platform to deliver better outcomes for our patients. And I think the major advancement that's going to take robotic surgery to the next step is the use of fluorescence imaging. We already utilize fluorescence for solid tumor identification and perfusion as it relates to kidney tumors and doing partial nephrectomies. But where I see fluorescence heading in the future is the use of fluorescence with conjugated antibodies to target specific body parts. So for example, if we're working on a prostate cancer, we bind a fluorescence fluorescence agent to an antibody to prostate cancer cells and use it in real time to guide our surgery. So for the first time in cancer-related surgery, we have a tool very analogous to what our soldiers have in the battlefield, like night goggle vision, where we can see the cancer in real time and use fluorescence to attack it with very little probability of leaving any cancer cells behind. And so any type of malignancy that can have an antibody build against it. So for colon cancer, it could be CEA, for example. You can bind that antibody to a fluorescence agent and use it to find the cancer in real time and make sure you don't leave any tiny cancer cells behind. So I think this is going to be a huge advancement that can be applied not just to urology but other disciplines as well. And I think it's going to have a huge impact on patient outcomes because it will probably limit the use of additional therapies such as radiation or chemotherapy that will potentially be required to clean up surgery that was not complete in the first place. So prostate cancer is the most commonly diagnosed cancer in men. It accounts for 1/3 of all cancers that men can have. And it used to be the second leading cause of cancer-related death in men after lung cancer. It's now the third leading cause after colon cancer. And I do credit that drop from number 2 to number 3 because of the use of the PSA test, although there's a controversy about it, and I'll get to that in a little bit. So it's a very prevalent cancer. At this point in time, about 200,000 men on an annual basis being diagnosed with it. One person is diagnosed every 2 to 3 minutes. In terms of our annual healthcare cost burden, it's about $8 billion, so it's very expensive, not only to diagnose these men, but potentially also treat them. We jump to 2015. There'll be 300,000 men diagnosed with it on an annual basis, about 3 million men living with it worldwide, and about 50,000 men dying from prostate cancer on an annual basis. To give you a little bit of perspective, that's the same number of men died throughout the Vietnam War over a 20-year time span. So that's a lot of people that are impacted with the disease. But that's not to say that every person that gets diagnosed with it necessarily needs treatment. There's been a lot of controversy with regards to screening with the use of the PSA. This past October, the U.S. Preventative Task Force issued a statement actually discouraging the routine use of PSA for prostate cancer. And it's caused a lot of concern among not only urologists but healthcare practitioners and patients. And I think you have to use the PSA test intelligently. The reason the U.S. Preventative Task Force came out with that recommendation is based on 2 large trials, one performed in Europe and one performed in the United States. The European trial, the ERSPC trial, followed almost 200,000 men over a 9-year time period and did note a slight improvement in survival in men that had undergone screening with the use of PSA although the US-based trial did not notice the same results. And there's been a lot of criticism and limitations of those trials in the sense that they didn't follow patients long enough, and there was a lot of contamination with pre-screening in both trials, so you wouldn't see as big of an effect of screening. I, as a urologic oncologist and as member of the American Urologic Association, agree with the guidelines that we came out with in 2009 that all men starting at the age of 40, regardless of their family history, but certainly if they have a family history of first-degree relatives diagnosed with prostate cancer, or if they're African-American men, should get a baseline PSA test and use that baseline to counsel them in regards to how frequently they should obtain other PSA tests to rule out the possibility of having potentially lethal but treatable and curable prostate cancer if it's detected early. Where I think we're headed is beyond PSA. I think PSA test is not a great test, but it's the only test to really have at this point in time clinically available. We're going to head towards other either urine-based or blood-based markers to give us a analysis of a man's risk of prostate cancer, and if their cancer, if they certainly have prostate cancer, what their risk of having any harm or dying from that disease is. Because not all prostate cancers are equal. There's certainly some cancers that will not grow fast and will certainly be present even when a person dies 15 or 20 years down the line, while there are very biologically aggressive cancers that can potentially spread and metastasize and kill someone in a very short time span. In the past year, there have been a couple of articles that have come out on urine-based markers looking at gene changes. One of them was Tempus ERG22, gene changes in urine tests of men, not only being a better predictor of who has prostate cancer, but who has clinically significant prostate cancer, meaning Gleason 7 or higher grade cancers that have the potential to cause harm down the line. Another study that came out this year is a 5-gene lethal prostate cancer test that can accurately differentiate between early lethal or aggressive cancers and dormant type of cancers that could certainly be followed through a program called active surveillance. I'm a big proponent of active surveillance for men who are appropriate candidates for it. You know, early risk, Gleason 6, small amount of volume, with not many cores involved. And what we've seen from a wide variety of studies, both from the United States and through Canada, is that a lot of men with early cancer that is deemed to be low risk can be followed expectantly and not undergo unnecessary treatment with either surgery, radiation, or any other ablative techniques. So I think we're going to get a lot more tests in the future, whether it be urine-based or blood-based, that can give us a better assessment of what type of cancer, if they truly have cancer, a person has.